found that um, the cervical SCI population had higher sway than, can you see this cursor? All right, so that's visible, right? Yeah. So the postural sway in individuals with SCI were higher than postural sway in able-bodied individuals. There was another study that also looked at rehabilitation priorities in individuals with SCI and regaining trunk control, as well as regaining posture. Postural control was one of the highest ranking priorities. So how is postural control actually maintained? And the mechanism behind it is based upon what spinal cord levels innervate the muscles responsible for maintaining postural control. As you can see in the dermatome map on the left as well, most of the muscles are innervated by the thoracic spinal cord, which are responsible for trunk extension, trunk flexion, and trunk rotation. And these muscles, the erector spinae, the erector abdominis, and external oblique muscles maintain the spine posture, especially against gravity, by an action of a coordinated action of flexion extension, as well as a coordinated action of concentric and eccentric activation of those muscles as well. These are slow twitch, fatigue-resistant fibers, muscle fibers, but they eventually fatigue, and that's why loss of posture, even in healthy individuals, is a subconscious action. This particular mechanism is affected in individuals with spinal, especially in cervical or upper thoracic SCI, and hence it is important to monitor the affected postural control of them so that they are not performing a lot of compensatory mechanisms like using their hands to maintain posture. For the monitoring of posture, especially in the healthy population, there have been different models, comprehensive models that have been studied, as well as there has been wearable technologies that have been studied as well. In terms of comprehensiveness, some studies have even been able to model to an extent that they're able to model two pairs of spine segments, whereas in wearable models, they are using as much as simpler designs as single inertial measurement units, a pair of measurement in IMUs, or to some extent 5 sensors as well. There are also flex sensors that can be used, strain gauges, and different smart garments as well for posture monitoring. All these models, however, as well as monitors, are built for the healthy population, and not many studies have actually tried to find the balance between comprehensiveness and wearability, because that's what's important for wearable technologies for the SCI population. There are other technology considerations as well when it comes to wearable devices for individuals with SCI. There could be design considerations such as having small footprint, being intuitive, portable, as well as scalable. And there are other implementation considerations such as easy to be able to wear and take off, cost effective, as well as maintaining skin integrity. There is an extra requirement for spine posture monitors with respect to individuals with SCI, and that is that it needs to be interactive so that it provides cues about inappropriate posture, but also be able to track responsiveness to those cues of how the participants are responding to posture feedback. And so what kind of posture feedback can be provided? There are spine segment inclination, could be spine segment inclination angles, so like angles of different segments of the spine, could be the spine curvature itself. Other spine posture data could be interface, so like sitting interface pressure hotspots, as well as distance between the wheelchair back as well as the back of the participants themselves. And the classification of how appropriate or inappropriate the posture is done by two different methods. One of them is threshold-based methods that looks at continuous outcome and tracking that continuous outcome, and also being able to provide error signals based upon the tracked outcome. There are also machine learning and deep learning methods that classify posture as appropriate or inappropriate. And from these classifications, you can provide posture feedback to the user uh, through different modalities, such as audible, like a buzzer, vibrotactile feedback, providing vibrations, or even through just visible through your like your mobile screens. Um, the feedback could also be directional, which is that it could be either generic or directional. Directional means if we are losing posture in a specific place, or specific segment of the spine, the system should be able to say that you're losing posture at that particular segment as well. So posture feedback in general has been widely studied, but posture feedback specific to seated task has not been explored as much. So what is task-specific posture information? Why is it important? There was this one study which looked at a pair of comparisons. The first one was sitting with good posture and sitting with hunched posture. And then the second was sitting with good posture versus leaning with good posture. And just using accelerometer only data, they were not able to distinguish between these two comparisons, whereas when they used magnetometer data as well, they were able to distinguish correctly. And the reason the system could be confused by these two different comparisons is because of the features of the system itself, and that to some extent, if I am leaning with good posture versus I am hunching, but then I'm not leaning, it could be interpreted as being similar to each other depending upon what features the system has. So we want to be able to accurately distinguish these comparisons as well. That's why we are focusing on task-specific posture, so like posture based upon what task is being performed. This is also important because it helps in tracking specific activity goals during long-term rehabilitation, like tracking quality of tasks being performed, quantity of tasks being performed, and that helps the clinicians to improve rehabilitation for individuals with SCI. In addition, the wearable trunk posture monitors have also been used to improve neuromodulation delivery by using feedback from these posture monitors and to be able to provide neuromodulation so that the individuals with SVI improve their posture as well. From all these, we can say that recognition of seated tasks being performed is critical to the accurate classification of posture as well as tracking rehabilitation goals. And when we talk about task recognition, there has been a lot of studies done, especially in the healthy population that looks at different tasks such as sitting, standing, walking, running, and transitions between them. There are also studies in stroke populations, especially with respect to hand movements. There are also, the only study I've found with users with SCI was recognizing wheelchair-based tasks. So like either sitting in a wheelchair or wheeling or interacting with objects in the environment, as well as arm exercises or arm ergometry. The common denominator in all of these task recognition software mechanisms were that they were using inertial measurement units, so like inertial sensors to perform these task recognition algorithms. Whereas there is a different set of gesture recognition systems, especially for individuals with stroke, that also utilize EMG information to be able to perform hand gesture recognitions as well. However, for individuals with SCI seated in wheelchairs for recognizing seated tasks. We believe that inertial measurement units should be enough information to be able to perform task recognition. So to summarize, as I said, spinal cord injury, especially at the cervical and thoracic levels, leads to problems with trunk stability. And then postural control improvements are one of the main priorities of individuals with SCI. These monitors, posture monitors, have been tested in the healthy population, but there is lack of posture monitoring options, especially in home and community settings, not just rehabilitation settings for the SCI population. And we focus this importance of task-specific posture because it helps in tracking quality and quantity of tasks during a rehabilitation program. And for this, task recognition is important, and including with task recognition and task-specific posture monitoring, it helps in improving neurorehabilitation. Hence, we'll move on to my specific aims, which is to develop the UofSpine system, which is an intelligent seated posture monitor to assess trunk stability improvements in individuals with SCI. Aim 1 is to design, validate, and test feasibility of the system. It consists of IMUs on the head, on the spine, on the shoulders, as well as pelvis and upper extremities. And we'll build a spine posture model to be able to monitor seated posture in able-bodied participants during static sitting and performing seated tasks. The reason we are having data from able-bodied individuals in this particular aim is because we want to be able to build a device for a large range of seated postures, and which would be later applied to the target population, which is individuals with SCI. Aim 2 is to test the efficacy of the system in monitoring posture changes in individuals with SCI, again, during static sitting and performing seated tasks. And Aim 3 is to develop and optimize machine learning algorithms that identify the task being performed using data obtained from the system. So I have some methods as well as results for specific Aim 1 of my study. Let's start with participant demographics. Again, as I said, we started with healthy volunteers. We had a total of 15 subjects with an average age of 30.4 years. 11 were male and 4 were females. And then 13 were right-handed and 2 were left-handed. And some of these demographics were similar to demographics of the individuals with SCI themselves, the population, where average age at injury is around 43 years, and then 78% of them are males as well. So to develop the model, we started with comprehensive configuration. We started with comprehensiveness, and then we were going to reduce it to being wearable. The starting configuration contained 14 IMUs with 5 IMUs on the spine at specific spine levels, pairs of IMUs each on the scapular region as well as the acromion of the shoulders. There is an IMU at the head, and then IMUs in the upper and lower arms. The reason we chose this starting configuration was they are able to provide us with head and spine posture, with trunk kinematics, with shoulder kinematics, as well as arm motion. And on the right is a figure of a participant performing during the assessment. So what were the assessment tasks? They were quiet sitting with various postures, hunched posture, relaxed posture, and then upright posture. They also perform forward leans in different postures. They will perform lateral leans in different postures, as well as reaches in different postures. The functional tasks were only performed in relaxed and upright posture, and only during the sitting task, they had performed hunched posture as well. The reason these tasks were selected because they they constitute basic tasks or basic movements that individuals with SCI perform during their activities of daily living, such as socializing, such as pressure relief or wheeling for commutes, such as transfers, or interacting with objects in the environment. So our first goal was to validate inertial outcomes compared to motion capture outcomes. And for those, for that, we started with the angular outcomes, which would be the spine segment inclination angles. So for this, we had 5 markers on the spine, shown in blue. And each of the segments created by pairs of markers that were adjacent led to giving these spine segment inclination angles. For the IMUs, there were inertial measurement units or IMUs in specific locations between those pairs of markers. And so those gave the relevant inclination angles from IMU outcomes. This was done in sagittal plane and frontal plane for sitting tasks, and for leaning and reaching tasks based upon the plane of movement. We compared the angles similarly as well. The target for the validation was that the angles, the difference between the angles or the root mean square error would be less than or equal to 4 degrees. We also looked at spine curvature outcomes. And for this, for the motion capture curvature, we just looked at 2D coordinates of those 5 spine segment markers, and just using B-spline interpolation obtained a curve. Whereas for the inertial measurement units, it's a little bit different. We obtain distances between the IMUs. And what we did was, using the distances and the angles in this particular plane of motion, we started from bottom, in a bottom to top approach. So using, for example, let's say using the distance between IMU that's here and that's here, which is S2 to L3, and then using the angle of the S2 marker, sorry, IMU, we obtain this intermediate point here. And then again, using the same distance, but the angle of the L3 IMU, we obtain the next position. And so alternating between distances and the IMUs, we obtain the whole curvature as well. This was based upon a previous study that this process was modified from a previous study that used similar mechanism to obtain curvature from IMUs. For the validation with motion capture versus spine curvature, we performed chi-square goodness of fit test, and the target for validation was the p-value should be greater than 0.05, which means insignificant differences. Also the Cohen's omega should be less than 0.1, which means negligible effect sizes. For this, what we did was, for each of the 2 curvatures at different locations of X, we found, we located Y positions for both the curvatures from MA and IMU and compared them. And then use linear mixed models followed by chi-square goodness of fit tests. So looking at the results of validation, these are the spine segment inclination angles. I know I said that my target was 4 degrees, whereas average of all of them seemed to be a little more than 4. But what I wanted to highlight was the ones that were a lot more, giving a lot more errors than expected, and those were specific to right lean and left lean, and specific to right reach and left reach, and towards the upper angles, so like mid-thoracic and cervicothoracic angles. And the reason that could be causing these deviations, we'll try to talk about it in a bit in the later slides, but um, looking at the angles with respect to time, in sitting, they had a pretty good agreement overall, even during relaxed as well as upright posture. But then, as we said, specifically to leaning and returning, the returning phase of lean. So like when they are leaning, they're going forward, but then they're returning back. There's a lag that is being seen in those returning phases compared to like the forward leaning phases. So you can see there is more agreement here versus here. And that shows in other angles as well as to some extent in all of the other leans and reaches as well, which I've not shown here, but that could be the reason why there's a higher error. And also specifically in reaches, especially lateral reaches, the cross-plane motion. So we're not, when they're performing reaches, I was not restricting motion of the trunk twist, basically. So like when I'm reaching like this, rather than reaching like this, participants could have been reaching like this, which is causing that cross-plane motion and lower agreement. And we'll move on to curvature comparisons. And I've just shown some examples from a participant's data. In forward lean, as you can see again, as the participant leans, there is a delay in the IMU curvature. Again, it's more pronounced in that return phase. But then when they go back to being static in the back, like back to the center, it's again similar to each other. So what could be the cause of this particular lag could be that we are not also restricting them from stopping at the end of the movement. So they were performing the leans and they were immediately coming back. So because of that movement of the IMUs, that could have caused that lag in the data. And this was also visible in left leans or lateral leans as well. So in the return phase, the difference is much higher than the leaning phases. So when we looked at outcomes for curve comparison, as you can see, especially in the relaxed posture with respect to leaning in the lateral leans, that the p-values were less than 0.05, indicating the differences were significant. Whereas there was a section in upright posture, especially in the forward reaching with right and left hand, that all of those outcomes were showing significant differences. I still don't know the actual reason for this, but my speculation is that with upright posture, their range of motion is going to be a lot more limited than with good posture, and because of that, the variabilities in the data are less, and that's what could be causing them to be different from each other. We also looked at, so these are just graphical outcomes for the spine curvature. As you can see with hunch posture, there is a little less agreement, but when we move on to relaxed posture, there is good agreement, especially towards the lower end of the spine. And in upright posture, you can see a hook kind of profile there. And that's because some of the participants were able to perform these tasks with a proper upright posture, whereas some participants were still hunching. And that's because of that, there were these hook profiles. In forward lean, as you can see in specific angles of motion, there are, to some extent, good agreements between the two data. Whereas when we go to extremes like 0 degrees of movement or minus 10 degrees of movement, the differences are much higher. In right leans, it's similar that to some extent, the differences are less, but then towards higher lean ranges, they are a little bit more different. The good thing is that all of the participants were able to perform leans within 95 to 115 degrees, and the outcomes were very close to each other. The same thing goes in the forward lean, where all of the participants were able to perform leans between 70 degrees and 40 degrees. We also looked at validating other outcomes, and one of them was head inclination angles, which is based upon a clinical measure that looks at the angle between the horizontal and the line between the C7T1 marker and the tragus of the ear, which we placed at the left ear. For the IMU, this angle was provided by the head IMU, which was placed in a headband obviously with an offset because they were not aligned directly to the C7T1 marker. For the shoulder inclination angles, we looked at the angle formed between the right scapular spine and the left scapular spine in the coronal plane. So like this angle, but in the coronal plane. Coronal plane is basically a plane that you're looking from top towards the body. And then for the IMUs, it was the difference between the orientation of the right scapula and the left scapula. So there were good agreements for head inclination overall, even during quiet sitting as well as forward leans. But then specifically with respect to shoulder inclination, the IMUs were not giving good agreement at all, even in 1 minute sitting as well as in leans. There is a little bit of correlation that with the motion capture shoulder angle dipping, there is a dip, similar dip in IMU data, but it's still, the range of it is still a lot. And we also looked at shoulder curvature, similar to how we performed spine curvature. And that was in the coronal angle where we looked at angles formed by 5 IMUs. Sorry, the curvature formed by 5 IMUs, which was the 2 IMUs on the shoulders, 2 IMUs on the scapula, and then the T1 IMU. But then again, with the results, we didn't have good outcomes. The validation was poor, as you can see. There is no similarities or even no correlation in those movements. When we just use data from 3 of the IMUs to obtain the curvature, there is initial similarities, but then there is again no less correlation or even no correlation in those outcomes. So the reason why this could be is, one of the reasons is that the IMUs that we are using are not oriented in the same planes. So like the IMU on the shoulder was placed facing top like this, whereas on the back, if this is the back, they were placed flat on the backs like this. So because of the different planes, so one IMU is this way, one IMU is this way, that's why we could have been getting issues with validation. There was another issue, which was that the IMUs on the shoulders had a technical problem and they could not obtain magnetometer data, so we could not correct for drift. Following validation, we looked at reducing the model. So like now we have this comprehensive model. We know it works for certain outcomes, for certain movements. But now we want to see if when we are able to reduce those, the model, can it still work equally good. And so one sample reduction I've shown here is just using, for the spine curvature, we are removing the two middle IMUs, so just using the three IMUs that's present. And as you can see, in the movements, the red is the original configuration, the green is the reduced configuration. There is good agreement, especially towards the lower end of the spine, but then towards the top, there is a little bit higher differences. But then in the sagittal plane leans, it's almost following it pretty close. And when we looked at the outcomes of the curve comparison analysis as well, only in right lean and left lean in specific phases, they were not equivalent. And with respect to doing it with upright posture, there was only one movement that caused less agreement. All of the others were validated with this specific reduction. So in conclusion, IMU-based up-spine system is capable of monitoring task-specific spine inclination angles, especially lower spine angles, a potential lag in the acquisition of IMUs, especially in the return phases, as well as the effects of trunk twist during lateral movements and lateral reaches is what could be causing lesser agreements. Within specific limits, spine curvature using IMU has good agreement with motion capture. And similar agreements were seen with an example of a reduced configuration when compared to the original IMU configuration. There were some limitations, as I said in my presentation as well. Some of the tasks assessed were not controlled in terms of starting position or target position. And validation results could be affected by the markers or IMU being placed over either participant's skin or over the clothes. Unlike spine posture definitions, the shoulder curvature, shoulder inclinations, there is no widely accepted definitions for those. And in addition to that, because of the technical issues that we had with shoulder IMUs, must have led to decreased agreement in shoulder curvature outcomes. Now, modeling head motion was also challenging because, especially in relaxed posture, because we didn't restrict head motion of the participants, but we did get good agreement in sitting and forward lean with head motion. So the next steps would be to pursue reduction of other IMUs with this first validation data set. Now, we also acquired data from for a second validation data set where IMU positions were altered, especially in the spine IMUs, as well as we added more spine motion capture markers to be able to get more comprehensive data for motion capture curvature. We'll validate those outcomes and we'll reduce those configurations as well. And from both the data set, we'll obtain test IMU configurations to perform feasibility testing first in healthy volunteers. So for feasibility testing, these are just data in progress, but what we wanted to do was we wanted to, for the data that's been shown till now, we just used the software that was provided by the manufacturer, and that was used to visualize the outcomes. But for performing feasibility and future tasks, future assessments, we are going to use a software development kit that was provided by the manufacturer and that was modified in C++. And then I was able to communicate the data from there to Python to be able to perform outcome generation and outcome display as well. So just an example video here. I don't know if it's very clear, but with the motion of my hand, if you can consider this as a model spine, let's say, and you can see with motion, the figure, that's the Python interface, it's moving as well. It's able to properly follow me during flexion motions as well as extension motions as well. So this is still in progress. The next particular thing that we need to do for feasibility testing is with respect to the wearable gear. So we are right now making mounts for the IMUs, and we are also looking at customized wearable gear like these ones. This is just an example, but to have IMUs mounted on the spine, the scapular regions, the shoulder regions, as well as the pelvis. And this is from the Perceptron Neuron mocap system. And then a similar system is actually present in Larry, which we are going to use as a sample to develop our own wearable gears as well. And for the feasibility testing, we will start with 9 reduced test configurations and perform feasibility tests for them. The participants will be responsible for resetting the IMUs and locking the IMUs into the mounts themselves or the slots, and then they will wear the test configuration. We will have them perform seated tasks that mimic activities of daily living in individuals with SCI, and then use IMU via upspine system and software to look at, to have them see their postures visually through a user interface as well. The analysis would be after the test configuration, they will be answering a questionnaire for perceived feasibility and acceptability in a home and community setting. And finally, the questionnaire scores will be tallied. And if the questionnaire scores are more than 75%, this configuration would be considered as feasible. And from there, we will obtain the finalized configuration. That will move me into the end of my specific aim 1 and to specific aim 2 and 3, which is to test the device in individuals with SCI, which is the intended population, and move on to the phase of performing task recognition with the IMUs as well. Because I'm almost out of time, I'm going to skip these, but this is a connected project which looked at using these IMUs in identifying and characterizing loss of stepping independence in individuals with SCI when they are training or when they're step training with epidural stimulation. Skip these. I have some acknowledgements. I want to thank Dr. Angeli and Dr. Russell, who are my co-PIs, and my dissertation committee. I also want to thank my volunteer participants, the staff at Bioengineering, the staff at KCERC, Kentucky Spinal Cord Injury Research Center, as well as the staff at Larry. So, references. Any questions? Yes, Dr. Susie. For people who are online, what Dr. Susi asked was specifically with respect to the lateral leans and lateral reaches. She asked if a trunk IMU, or an IMU on the side of the trunk would help capture some of the twist issues. I believe that is possible, Dr. Susi. What we have done is in the second validation data set, I forgot to mention, but we limited the movements of the lateral leans into single planes. So like rather than twisting, we ask them to try to move in that one plane. So we want to see results from that and see if it can still be validated. And I think if that happens, then maybe you are right. It could be that trunk twist. Um, but if it still gives those problems, then it may not be the twist as well. Yes. We kind of for the people like online again, the question was with respect to the reduction, where the two IMUs that we reduced, we were able to find that those were redundant. Um, what I want to say is I did expect that to happen to some IMUs, but we were also looking at different motions, right? To some extent, um, especially in the leans, as you can see, towards the upper end of spine, with that reduced model, it's showing greater differences. So we could also add another sort of machine learning algorithm there itself to see if, with respect to different lean angles, maybe we can add different factors to it so that that curvature is even more similar. Oh, I don't think so. All right. Well, thank you, everyone. Thank you all and have a good week. On your way out.